Hi, I'm Venu Nemani, one of the spine surgeons at Virginia Mason Medical Center in Seattle, Washington, and this video is going to be a demonstration of a cervical disc replacement using the Mobi-C implant. Mobi-C is an implant that's been around since the early 2000s, has over 20 years of data in Europe and over 10 years of clinical data here in the United States. It is a semi-constrained implant with a polyethylene on metal bearing surface and has indications for both single and two-level use. All right, so here we are getting ready to do a cervical disc replacement. We're at the C4-5 level, which we can see the important parts of patient positioning for this case are that you want the patient positioned supine, obviously on a radiolucent table. Unlike an ACDF where you want the cervical spine in extension to promote lordotic positioning, in a cervical disc replacement, you want the patient really to be in a neutral position. So rather than putting a bump underneath the shoulders, you're going to have the bump underneath the cervical spine, which acts as a little bit of a backstop for when you're placing the trials and an actual implant to ensure more neutral positioning of the cervical spine. Also, you want to make sure that you have the patient positioned perfectly orthogonal to the floor, so it's a good idea to get preoperative AP and lateral x-rays to make sure that you have a perfect AP with the uncinate and pedicle symmetric on both sides, as well as a perfect lateral x-rays with the facet joints overlapping and a perfect lateral of the disc of interest. You can see here on the x-ray that we have a very nice lateral view of the C4-5 disc space, which we're going to be operating on. So here we have the anterior cervical spine exposed. So this is the C4-5 disc space here. The retractors are under the longest colli bilaterally. Once I get to this point, I start with generally looking for an area that's about equidistant between the longest colli to get a general sense of where my midline is. And so I'll take my bovie and I will bovie directly into the disc space itself, which is here, and then onto the vertebral body. And more in a disc replacement than even an ACDF, you're going to want to be really sure and careful to position the implant exactly midline. So I will make several different marks to confirm my midline location. And so I'll usually make a bovie mark there, and I will usually just at the beginning of the procedure, I will actually take a blue marker and mark what I think is midline just based on longest colli anatomy. And then later we'll confirm that using our uncinate as our landmark. Typically you'd use a protected bovie tip here so that you're protecting the surrounding tissues. But once you have the midline marked, then you're going to want to expose the vertebral bodies. This can be done bluntly or sharply. I typically will do this using a bovie, although you can do this using bipolar as well, and a Penfield elevator. So here I've incised the anterior longitudinal ligament off the C4 vertebral body. I'm going to find the inferior end plate of C4 as well, and staying within the disc space is safe, because then we can take this bovie all the way out to the uncinate. So here we are within the disc space at C4-5, and here we see the uncovertebral joint here on the patient's left side, and then here we'll come over on this side. And in the same way, we'll find the uncovertebral joint, which is right there on the patient's right side. And we'll also incise the anterior longitudinal ligament on the C5 vertebral body. In this way, we can fairly quickly expose our disc space of interest. Okay. So now here, it's nice to be able to smooth the front of the vertebral bodies. You can do this using a burr if there are any bony osteophytes here at this level. I like to often do this with a Lexel, so I'll take a Lexel rongeur. All right, so then we take a 15 blade within the disc space, and I like to make these cuts starting on the inferior end plate like so. On a typical 15 blade, the cutting surface is 11 millimeters, and so you can measure the preoperative depth of the disc space, and as long as it's greater than 11 millimeters, you can bury that blade. I will cut along the inferior surface until I hit the uncinate, and then slide up to remove the disc right off the uncinate until I hit the cranial vertebral body. Then I will start there. You can use your sucker to protect yourself in the direction you're cutting. So then we'll remove this disc here off the cranial midline. Then in the same way, we'll start again on the inferior end plate. We'll cut towards the So we slide up the uncus like so until we hit the cranial vertebral body end plate, and then again we can cut towards the midline. So here we've excised that disc, so we can then take the pituitary to remove portions of this disc material. You can see that if we make our scalpel cuts appropriately, that disc will come off pretty easily. I'm just going to reorient the microscope here, so now we're looking down our disc space. Okay, so now we have a view down our disc space. Next I'll take a curette. When doing a cervical disc replacement, you ideally want to minimize how much bony debris you're creating, and so ideally there's minimal use of the burr. It's not wrong to use a burr if you need to. You just need to be mindful not to remove end plate, and you're really using it to remove cartilage. So you can see here I'm working on the inferior end plate, removing the cartilage off of the C5 vertebral body. So, and we're working systematically, starting superficially. I'm trying to get all the cartilage off from uncus to uncus. And so you can see nicely the uncus on that side. And we'll do the same thing on this side. Okay, and then in the same way, we're going to remove our cartilage from this superior end plate. So with an upgoing curette, you can start deep and pull towards yourself, which often is a good way to get this cartilage off. The reason why it's important to get all this cartilage off is that the implant, in particular the Mobi-C, has an on-growth surface on both its superior and inferior end plates, and so you want to get rid of the cartilage because the ability of the implant to bond to the bone, to the surface, depends on the bone actually being exposed. So this is the time to get all this cartilage off rather than after you've done your decompression where the dura is exposed. So here we have all the cartilage off. We'll get a pituitary. And you can just irrigate this out or pick out all of the cartilage that you've scraped off of the end plates. All right, so here we are. We have all the cartilage that is gone now. Now with the Mobi-C, it has a domed implant geometry, and so for this implant, you want to typically preserve the dome nature of this. If you need to, for decompression purposes, it's okay to resect a small portion of the overhang. In this case, this is a fairly big disc space, so we're not going to need to do that. But in general, you want to try to preserve as much of this dome as possible. Here again, at this point, once you've gotten all the cartilage off, you can confirm your midline, so you can look for your uncovertebral joints bilaterally. So here we see one uncus, the other uncus, and so our midline looks to be fairly accurate right here. The other way to confirm midline is using X-ray. So at this point, the vast majority of surgeons will utilize Caspar pins to provide some disc space distraction. And so here we'll put in some Caspar pins. And we typically do this with the assistance of fluoroscopy so that we can make sure that the Caspar pins are perfectly parallel to the end plates and symmetric. This allows for symmetric distraction of the disc space. If there's any question about where midline is, you'll also want to use AP fluoroscopy to confirm that you're putting the pins exactly in the midline. In this case, we're going to use our uncovertebral joints to guide our midline, and so our top pin will go here at least about 5 millimeters above the end plate, and the bottom pin will go 5 millimeters below the end plate. One pin will go there. So here we can see our 14 millimeter Caspar pins. This also starts to give you a sense of sizing because you can see that the 14 millimeter pin in C4 essentially goes back to the very posterior aspect of the vertebral body. So we're estimating that the depth of this disc space might be around 15 millimeters just in terms of our size. So you can see here as we apply pin distraction, we get a little bit of distraction in the disc space there. X-ray, please. Great, and you can see that distraction on the images. Do notice that there is some distraction of the facet joints happening as well. That is something that we want to avoid when we actually put the implant in, to avoid oversizing to prevent distraction of the facet joints posteriorly. So here I tend to use a drill to do my decompressive work. Again, if you want to try to minimize this as much as possible, but ultimately you still want to make sure that you get a very good decompression, even more so in a disc replacement than in an ACDF, because there is still going to be motion present, obviously. So we'll continue here. We're close to the posterior longitudinal ligament. So we will thin this out. The feel of this is obviously a little bit different in a cadaver than it is in a live human. I will typically use the burr to make this quite thin. What I will also do with the burr at this point is I will flatten out any uncinate overhang here, because this will allow our implant to be wider. And so I'll look for any uncinate overhang, and if there's a little bit of the medial uncinate, I will flatten that out as I'm doing here. So you can make that straight. So here's your posterior longitudinal ligament. Same thing on this side. So now we'll take malus, and we can basically get beyond the PLL. I think we have our rent right here. Take a kerrison tube, please. And once we've got thinned down the PLL, we can then take our kerrison and do a complete resection of the PLL. Some people will not resect the posterior longitudinal ligament unless there is a extruded disc fragment. I think that is a little bit of preference. I think the one thing that's very important is you want to make sure that you have a very complete decompression of the neural elements in a disc replacement. The last couple beats in the framing, and then we're thoroughly decompressed. And there we are. So now we have a complete decompression of the spinal cord. You can see the dura right here. The PLL has been completely removed. And then let me take a small upgoing curette, or how about a malus instead. And we can see here that we can easily pass this instrument out. So that's the left C5 nerve root that I'm following right there. And here's the right C5 nerve root that I'm following here, right there. So that's totally decompressed. Okay, so at this point, we confirm that we have all of our cartilage. If there's any cartilage we can see remaining, we'll remove that with a curette or with burr, just being sure not to remove any bone. So once we have all of our decompression complete, we'll typically use some irrigation, make sure that we have gotten rid of any bone dust, gotten any hemostasis at this point. And now at this point, we're ready to begin sizing our implant. So in this case, we've already estimated that it's going to be about a 15 millimeter depth. There are some sizing tongs that we can utilize to assess the width. And so these tongs come like so. So here, the depth of these tongs are 15 millimeters. The width, you can see as I put this in, that it rides up a little bit on the bottom, and where it's getting hung up here is on the uncinate, both on the left and right side. So here we have two options. We can either go to a smaller size implant, and so that would be both a smaller width and a smaller depth, or we can take down some of that uncinate on both sides to allow this to sit flat. In this case, we're going to take down some of the uncinate just so you can see how that's done. So we'll start first on the patient's left-sided uncinate. We can shape this so we can basically flatten this out here like so, and we can take down some of that uncinate. If there's any question about the width of the uncinate, you can take a Penfield elevator and slip it lateral to the uncinate to see the actual width of the uncinate, to make sure that you're not endangering the vertebral artery. Okay, so we've widened that a little bit. We're going to take that just a couple millimeters more. And make sure we take this back to the posterior aspect of the uncinate. So there we go. So we've widened that side. We'll do this symmetrically on this side. The nice thing about having our marks and our Caspar pins lined up at the midline is that we don't lose reference as to where midline is. Again, if there's any question about the position of midline, you can always get an AP x-ray to confirm. After this is done, we're gonna get do some irrigation, wash out the bone dust. Okay, so we'll just irrigate this out a little bit. All right, then we'll take those tongs again. And so you can see now it's nice and flat, right? So now we have something depth-wise, it looks like it reaches just back to the dura, and it sits nice and flat on the infrared plate. So now we're ready to trial. So the most common sizes in terms of height, so we talked a little bit about the height of a cervical disc replacement. You want this to largely be a implant that is, you want the smallest possible implant that's going to fit in the disc space and not have any facet distraction. In the Mobi-C implant, the smallest sizes are a 4.5 and a 5, which probably represent about 90% of the implants that are placed. And so we're going to start with a 5 implant. You can see that the trial itself has a circular dome on top and is flat on the bottom. The dome matches the concavity of the superior end plate, and so we're going to place this with the dome facing up. Recall that we also have some distraction currently present on the, we use it with the Caspar pin, and so we will release that distraction once we have this in. I'm using my mark as well as my Caspar pin as a guide for midline, and you can also see that I'm symmetric between the two unsonets, also giving me confidence that I am placing this in the midline. Again, if there's any question, you can get an AP X-ray to confirm. Take a mallet. And we're going to put this down. You do this using fluoroscopy guidance to confirm that you are placing this to the correct depth. All right, and let's get an X-ray. So we can see here that that implant from a depth perspective is the correct depth. What we can also see in vivo here is now that I've resected part of the medial unsonets that we do have a little bit more space laterally. And so I'm actually going to see if I can get in one more size greater width. So we'll keep the 15 deep, but we'll see if we can go to a 19 wide trial and see if that sits down nicely. Ultimately, you want very good end plate contact while also maximizing the footprint of the implant. And so you can see that this fills the disc space medial to lateral. I'm going to remove some of the Caspar pin distraction at this point, just so we can get a look at what that looks like without the distraction on board. So to me, that looks like an appropriate sized implant. Recall also that this is someone who's not bearing weight with gravity, and so when they stand up, there's going to be some loading of that implant. The facets are not distracted. I think anything bigger than this, we're going to get some facet distraction, and so this will be the implant that we would choose. Okay. So the other things to notice is that the trial has a circle that's there. So you want that circle to be perfectly circular. As you can see here, that's we can play with the rotation. So why don't we get an X-ray there? So you can see as I change the rotation of that circle becomes more of an ellipse. And so we can adjust the rotation to the correct rotation, X-ray there. And you can see there now it's a perfect circle. And that's essentially the rotation of the implant that where it'll be in the correct position. So now we can put our distraction back on. We can take our trial out. We can do a final check to see if there's any cartilage that needs to be removed and remove that if necessary. Once we have made all those checks, we can then have our implant. So you can see here the implant has this inserter. If you look at the implant itself, you can see that it's got a porous coating. This allows for bony on-growth onto the surface of the implant. It has some teeth that allow that prevent it from backing out of the disc space once it's in there. And then you can see that there's a dome-shaped surface on this side, and that dome shape is going to be facing up. Okay. So once we have this in place, we're going to center this, and so you can see that blue marker. As well as the Caspar pin allows us to set our medial lateral location, okay? And then we're going to come back in with X-ray. So now you can see there's the implant, so it's in line with the disc space. We can use X-ray guidance to get this in place, X-ray. So now we are in a good position right there. If there is a need to countersink the implant or to put it down a little bit more, there's a dial on the inserter such that you can advance it by small increments if necessary. Okay. So at this point then you'll want to remove the inserter itself, and so there's a blue donut type instrument that goes on top. You'll want to turn this at least 20 times clockwise to allow yourself to remove the implant. Once you've turned it a lot, 20 times, turn it at least 5 more times. So once that's off there, then you can gently rock this side to side to remove this. And then there's a removal tool that you can then use to remove the final plastic holders. There's also a tool if you need to make small adjustments to the end plates itself. There's a small tamp, so we can see that perhaps this needs to go in just a little bit. This tool has a deeper end and a shallower end, so the deeper end goes onto the polyethylene, and then you can use a mallet to countersink the end plates just a touch if necessary. And then we'll often try to get the superior end plate just about 1 millimeter posterior to the inferior end plate, and this tends to lead to a good position of the implant when they're in the standing position. So you can see there the final position of the implant. Perhaps could be 1 millimeter more superficial on the cranial end plate, but I think that looks like a perfectly acceptable position. At this point, we're going to take off the Caspar pin distraction, and I'll usually compress it a little bit just to squeeze the end plates onto the implant itself, and then we'll remove the Caspar pins. As you can see, we have maximal coverage of the implant from a front to back standpoint. And then once you, obviously when you pull the Caspar pins out, want to make sure you're not wrapping up any soft tissue. You can use bone wax then to cover the holes to prevent any bleeding. And there we are. So that's the final implant. Then we're going to get an AP X-ray and show our final image there. We can pull the retractor out and get our final images here. Okay. All right. And then can we come to an AP? Okay. So because of the head holder, we have this at a not a perfect orthogonal angle, but you can see that's in the midline.